Welcome to the Nursing Post podcast, All Nursing All the Time with Ashley Moore and Rosa Horsley. This week we'll be talking about endometriosis. Our goal is always to inform and start conversation.
If you are a woman, you are quite familiar with your monthly visitor, and we all hate the visit. Hope she'll be nice and leave as soon as she can. For women who suffer with endometriosis, this monthly visitor is anything but nice.
It's like house guests.
Yes. That don't leave and they're awful and they leave a mess.
Here are some statistics, as we always love the numbers. Endometriosis affects people mostly in their reproductive years, ages 12 to 52, and can even affect those in their youth. On average, there is a 7 to 10 year delay in diagnosis. About 1 out of 3 women consults 3 to 4 providers before receiving a diagnosis. Endometriosis is one of the leading causes of infertility. Endometriosis affects an estimated 2 to 10% of American women between the ages of 25 and 40. And you may be asking yourself, what is endometriosis?
And I would like to say, you probably feel the same way, Rosa, 7 to 10 year delay in diagnosis.
That's
because
a lot of years, yeah.
I feel like so many doctors are like, well, yeah, of course you're going to have cramps when you're on your period. Of course you're going to have this issue. You're a female. And we're not taken seriously.
I mean, I have a whole story just about my personal experience about that. But
Right.
We'll get into the bread and butter and then kind of talk about that.
Sure. So with endometriosis, during a normal menstrual cycle, tissue builds up and then it sheds off when pregnancy does not take place. Ladies who have endometriosis develop tissue that looks and acts like endometrial tissue, but it's outside of their uterus. And it can even develop on other reproductive organs inside the pelvis or in the abdominal cavity. So like your intestines or your ovaries.
Mm-hmm.
Every month, that tissue that's not where it's supposed to be outside of the uterus responds to the hormonal changes that happen every month during menstruation by building up and then breaking down. And it causes, small bleeding inside the pelvis. It causes inflammation, swelling, scarring of the normal tissue that's supposed to be there. And that surrounds the endometriosis, and it's called endometriosis implants that occur because of the abnormal shedding of that endometrial tissue. Mm-hmm. So it's normal to have endometrial tissue that develops and sheds inside your uterus.
Absolutely. It goes through your uterus, through your cervix, and out with your menstruation. That's how it's supposed to work.
Yes. And when you have endometriosis, you have that special tissue that's only supposed to be inside your uterus, outside of your uterus. Mm-hmm. And every month it wants to act like it's supposed to. It doesn't know that it's not inside your uterus. So that's where the problem starts coming.
That's where a lot of pain, discomfort, and a lot of the other things that we're getting ready to share with you come from.
Right.
So some of the signs and symptoms of endometriosis include pain. It is the most common symptom, and with different kinds of pain.
Right.
Like it's not just stabbing, shooting, it just, depending on where that endometrial tissue decides to implant itself, mm-hmm. It can cause different types of pain. And these include very painful menstrual cramps worsening over time. Chronic, which we all know is another word for long-term pain in your lower back and pelvis. It can cause pain during sex, and it's usually described as like a deep pain. Intestinal pain, you can have painful bowel movements, pain when you're urinating during your menstrual periods. It's in very rare cases, you may even have some blood in your stool or urine. It can cause stomach and digestive problems. So you may have diarrhea, constipation, bloating, nausea, especially during your menstrual period. And I know a lot of people are thinking, well, that's me every time,
yes.
My cycle starts. You have bleeding or spotting between your menstrual cycles, and infertility is a big sign or symptom that you may have endometriosis, the inability of, being able to get pregnant, purposely attempting to.
Right.
The risk factors include any girl or woman who has menstrual periods, and it's more common in women in their 30s and 40s. But like Ashley had said, and, there's usually a 7 to 10 year delay of diagnosis. So pretty skeptical about that 30s and 40s.
Right. Well, I think that's when people are diagnosed is in their 30s and 40s. Maybe they're taken a little bit more serious than somebody that's in their 20s or late teens. Unfortunately,
yes.
But I'm just trying to be quite frank.
Yeah. And so you might be more likely to get endometriosis if you have developed your period earlier in life. So 12 and a little earlier. If your body weight is low, if you've never had children, if your menstrual cycles last more than 7 days, if you have abnormal or heavy bleeding, if you have intercourse during your periods, if your cycles are 27 days or fewer, if a family member has been diagnosed with endometriosis, genetics always has a lot to play in health. A health problem that blocks the normal flow of your menstrual cycle from your body during your period. And that's like, cysts, fibroids. It's like a total different subject, but those are the kind of things that can impair that flow. If you drink alcohol and if you smoke, because remember, smoking constricts, it doesn't dilate.
There are different ways to diagnose endometriosis, and usually, as with everything in medicine, it's a combination. You'll start with a pelvic exam, which most women are very familiar with. And during your exam, the provider actually will feel for any abnormalities like cyst or scar tissue. Endometriosis is not always felt, but usually it's the first step. If they feel something abnormal, you're going to probably go for an ultrasound, which is the second thing here on my list is an ultrasound. And they can either do an abdominal ultrasound or a transvaginal ultrasound, or you might get both.
Yeah.
And both types of the ultrasound are usually done to get the best view. So there's things that you can see in a vaginal ultrasound better than you can see with an abdominal and vice versa. A standard ultrasound won't definitively tell your doctor if you have endometriosis, but it can identify cysts that are common with endometriosis. You may get an MRI, and that uses radio waves to create images of organs and tissues on your body, and that's for any MRI. And it really helps with surgical planning and giving your surgeon detailed information and location of where these endometrial implants may be. Lab work is done to rule out other diagnoses, and then the one that I think is probably the most common, in my opinion, is laparoscopy. And that is just when they make a couple of small incisions and look in there with a camera. I've always called it an exploratory
That's
lab,
what I had known it to be.
Yeah. And so that's when they go in there and see if they can see any of the endometrial tissue. And if so, if they can try to remove it.
Take samples for biopsy and testing.
And so, and sometimes it's just only for diagnosis. They literally go in there and look, biopsy, and then they're out. Hormonal birth control is a great treatment option. And this is for all hormonal birth control, orals, injectables, patches, IUDs. And what that does is it helps stop menstrual periods and the growth of endometrial tissue, which can, in theory, help from that endometrial tissue forming outside of the uterus.
Because you're skipping your cycles. Right. So when the thought process makes sense.
Yes. There's surgeries that you can have done, an ablation, and that's where they go inside the uterus and essentially burn the endometrial lining within your uterus. Excision, and that's where they just cut out the lesions, the endometrial lesions, as best they can. And then you may just have a full hysterectomy, which is the removal of your uterus and possibly your ovaries, depending upon how advanced
severe it is. Yeah.
And then there are a couple medications in addition to birth control, gonadotropin releasing hormone agonist and antagonist is a group of medicines, and those medicines block the reproduction of ovarian stimulating hormone, and that lowers estrogen levels and prevents menstruation. It causes endometrial tissue to shrink because those medications create an artificial menopause, really. And taking a low dose of estrogen or progesterone along with those medicines could decrease menopausal side effects and menstrual periods and the ability to get pregnant return once you stop taking these medicines. So that is kind of a nice side to that, you know. And then another class of medicines are the aromatase inhibitors. These are medicines that reduce the amount of estrogen in your body. There are several different medicines, anastrozole, exmestane, and letrozole, and they can be combined with oral contraceptives to help treat endometriosis. And I'm familiar with these medicines being treated, one in particularly for breast cancer.
It's so important as nurses that we show our patients support. You know, if infertility is impaired, that patient now carries that burden of the potential future loss that they had to become a mother.
Right.
And that's definitely traumatic for someone who wants a family and is unable to physically produce one of their own. You have to also understand that there are fluctuations and hormonal levels that often result in women having this emotional roller coaster.
Oh, absolutely.
As a nurse, you need to be incredibly supportive to patients who have undergone these surgical procedures. And you have to also keep in mind that they are suffering, they're in pain. And not only does this affect them, it affects their partner as well.
Yes.
Because, you know, a lot of times there is pain with intercourse. And so communication is key, and it can be frustrating for both the male and the female in the relationship. And you want to let them know that it's okay to try different positions. Right. I had this doctor tell me one time, and I'm sure if anybody in this town probably listens to this, they're going to know the physician I'm talking about. He would tell me to drive the bus. And so you just kind of need to work with your partner and feel comfortable enough with your partner to find intimacy that works for the both of you, right, and not to be ashamed to talk about it.
No.
You know, you can experiment with different things and try to make intercourse as pleasurable, you know, at certain times of the month. Can be less painful for you at some point in the months than in other parts of the month. Just keep checking on your ovulation and, you know, that 2-week period after having a period. It's just super important that patients get supported. And like Ashley was mentioning earlier, I think this is probably a good segue for me to put my little 2 cents in. I was actually diagnosed with endometriosis, and the start of it was just so frustrating because you go to your PCP, you tell your PCP, you know, something's just not right. Like, this doesn't make sense. You tell your PCP does what? Refers you to OBGYN.
Yep.
So then you're going through this conversation with your OBGYN, and you keep having this conversation with your OBGYN. And at one point I was taking birth control. I tried almost all of them. The one that I remember, which now is probably a generic, is Seasonique, where you could go 3 months and not have a period.
Yes.
But our plan was to go straight through those placebos and that way you don't have one.
Right.
I tried Lupron depot shots. If you're not familiar with that, that's what they treat prostate cancer patients with because of the hormones that are inside of it. It had gotten to the point where they referred me to pain management because everything they tried just wasn't working. And I just got fed up one day and I said, you know what? Refer me to such and such, which is a medical, training school, university, college, whatever.
Right.
That was close and near to us. And then I had to go through
the whole
process
all over again.
And mind you, I was 22. And at that point, I just said, Dr. So-and-so, I can't keep doing this. Like, everybody's thinking I'm crazy. I'm in so much pain. This is affecting my marriage. This is affecting my ability to function. It was to the point to where it hurt to walk. It was that painful. And she said, well, Rosa, the only thing that's left is, exploratory laparoscopic surgery. And she's like, you're super young. And I told her, I need the peace of mind.
Right.
I need the peace of mind for myself because I can't walk around feeling what I'm feeling and knowing that I'm going through it and that it's just all in my head. And she looked at me and she said, that is such an adult decision. And I remember scheduling the exploratory surgery, going in at 9:00 in the morning. If you've ever been in that university's outpatient, op center or whatever, they have windows all around the top.
Okay.
So it brought in natural light. And I remember her telling me, it'll only take 45 minutes. I remember coming out of surgery and it was no longer light. It was dark.
Wow.
So the first thing I said was, pardon my French, what the hell happened? Why is it so damn dark?
Right.
And she was like, well, you were right. She was like, you do have endometriosis, and it was all over the place. And so while she was in there, she took the time to cauterize as much as she could. But had I not followed my gut and been my own advocate, I would have probably still been suffering today. So it's very important.
Yes.
As women, because we know our body and we're told so many times, oh, like Ashley said, it's just, that's normal. You're supposed to have cramps. You're supposed to have pain. You're supposed to be a little bloated. You'll be constipated. We hear that so much.
Oh, yeah.
Just drive the bus.
Yeah.
That it makes you feel insecure. And for a moment, I really did think maybe I should be like talking to a shrink. But that was my confirmation. The fact that that doctor was willing to listen to me and go ahead and do the exploratory surgery.
I just think that it's interesting that the default for a lot of this, in my opinion, is that the patient's being overly dramatic. And I think that until you personally go through something, or maybe have somebody that's close to you that goes through something, you just can't sympathize with certain things. But if you can't sympathize with it, then, and you don't know what it's like, then you don't have, in my opinion, the right to judge.
Absolutely. I am not sexist in the point to where I only have to have a female doctor or I only have to have a male doctor. There are some patients that are that way.
Yes.
All the way across the board.
Right.
I think I've had between C-sections, exploratory surgeries, and babies that at this point, I don't care who sees my hoo-ha.
Right. Well, I mean, at that point,
like, who gives a damn? But
right.
But I feel like men don't have menstrual cramps, so they cannot empathize.
No.
You may say, oh, I'm sorry. You might be able to say, sympathize, which is saying, oh, I'm sorry. But they can't empathize. They can't say, oh, I know how you feel about that. And this is not a put down to male physicians.
No.
I think my thing is, if you're going to a male physician and he's not hearing you, especially OBGYN, if he's not hearing you, then you need to go ahead and have a second opinion.
Well, anybody for sure. If you're with somebody that's not listening to you, or you feel like you're not connecting, then that's maybe not the right doctor for you. And I'm a big believer in that.
Absolutely.
it's just a little bit different because I know when I was having the same problem, my first step and first couple of steps was all STD testing.
Oh, yeah. They start there. Absolutely.
And I remember, everything came back fine. And one of the doctors that I worked with was like, hey, how are things going? Just because he had witnessed me having it wasn't like an awful day. It was just a bad day. Mm-hmm. It was a day where it kind of hurt to sit, hurt to walk.
Yeah. It's uncomfortable, man. You can't find any relief.
No. And, he was like, you really need to go get that checked out. You need, this whatnot. And I'm like, yeah, I have an appointment, blah, 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 blah. And when I came back and he saw me, I don't know, probably about 4 or 5 days later, he's like, hey, how'd your appointment go? What'd they say? And I said, oh, I don't have any STDs. And he laughed. He thought I was joking. And he like waited. I was like, no, seriously, that's all I found out. He's like, that's ridiculous. And it just got to the point where they said, this is probably what it is. It's probably this. Call me when you're bad. It hurts bad enough that you want to have surgery. Yeah. And that was the end of the conversation. And when it hurts bad enough and you want to have surgery, let me know. We'll do the surgery. And I was like, oh, there was no education on
what it is, how to cope with it, how to medicate. I know back in the day when I'm in my 40s now, like I was 22, there were no support groups. There was nothing. It was not even very common back then.
No, I remember coming home and talking to my husband. They were like, they think that it's this. There's no way to know unless you do surgery, mm-hmm. really, for sure. And I just looked it up, and he was like, yeah, that's hitting the nail. Yeah. You don't have all these, but you have most of these, and
so chances are,
And I'm like, yeah, well, it'll just get to the point, like. The doctor said, hey, let me know when you're ready to have surgery.
Yeah. We're fortunate enough that we have children. Mm-hmm. And so, even though I went to see this female specialist, I still kept my male doctor in town because he's still a good doctor. He just couldn't empathize with that because he had never experienced it before.
Right. Well, and I'll be honest, even as a female who had my period for years before I had any problems, I didn't have any problems until after I had kids.
Bingo.
And I remember thinking, this is not like a normal cramp. Like I'd had cramps for years, and I have been on birth control for most of my life just because I did have very heavy periods when I was a child, and I bled more than I didn't when I first had my period. And I just remember him saying, stay on birth control. And I'm like, well, duh. I don't want to have kids. I really wasn't worried, I didn't link it together until I literally went home and did my own research on it. And to be quite honest, I think the doctor that I had, he's now retired, was a great doctor, actually. Mm-hmm. He was very, very good. He was highly recommended by most of the people that I knew. And it was just funny. And maybe it's because he knew I was a nurse that he just didn't think to take the time to explain it to me, that I would go home and look it up.
You knew it, yeah.
And I'd be on about my way, which is ultimately what I did. I didn't have any questions or anything like that. And it was just kind of one of those things of, in the back of my mind, I just know that it's going to get worse. Mm-hmm. And I'll call when I'm ready to have surgery.
And that's what, I remember going in for my annual with my male doctor and still with the same complaints. And he was like, he was just like, Rosa, like, do you plan on having any more children? Because you physically can't. You're blessed enough to have these 2 kids. You're suffering, like you're legitimately suffering to the point where it's disabling you. He's like, what are you waiting for? Like, why won't you just go ahead and have the hysterectomy?
Because we're control people.
I am a control freak. I don't like surprises. You know that.
Yes.
I hate surprises. I want it on the calendar. I want to plan. I want to plan it, and I want it on the calendar. And
it's so funny because I love surprises, and I don't mind surprises at all.
No, I hate them.
It's fine. But I know Rosa doesn't like them enough to call her the night before to be like, hey,
please warn me.
She's like, I'm so glad you warned me. I don't like surprises.
I hate surprises.
So if you ever have a surprise for Rosa. Don't tell Ashley because Ashley's telling Rosa.
Thank you,
Right
Ashley.
before you
I
surprise
appreciate
her,
that.
I'm going to be like, all right, now look, sit down. We got to talk. But I don't ever start it off like that because then it'll get her anxiety
Yeah.
up. I'll be like, hey, this is what's going on. She's like, oh, what? Huh?
Yeah.
So it doesn't really.
I do. I have to have time to marinate.
Yes.
So when I left that appointment, I marinated,
Yeah.
and then I called the doctor back, and I was like, you know what? I told him I'm such an idiot because everything you said was right. Like, I physically can't have any more children.
Right.
I'm in pain all the time.
Mhm.
I was like, you know what? Just do it.
Yeah.
Let's be like Nike and just do it.
Right. Take it out.
And I'm telling you, he had to end up taking one of the ovaries, but he said it was probably the best decision I had really ever made in a long, long time.
Right.
And I've been living my best life since.
Yeah. I'm just hoping that all the hormone, the birth control that I'm on will let me ride it out for as long as I can. But I do know it's worse now than it was 5 years ago.
Well, I'm just going to put this caveat in there because in the beginning, like I said, the only treatment they had was birth control, but they don't tell you all of the side effects that come with birth control.
No.
Like everybody knows, don't smoke. You have a higher chance of throwing clots even when you're not smoking and you're on birth control.
Mhm.
But no one ever said to me, hey, Rosa, being on birth control from 22 to however old, it was that it took me to have my hysterectomy, they don't tell you that one of the side effects to birth control are cysts on your liver.
Mm-hmm.
And that was one of the side effects that I had. And because of having all that birth control and hormones, I can't take any type of like hormone therapy or replacement hormone therapy that a lot of women usually would do when they're menopausal.
Right.
So I definitely would say as a nurse to patients that are experiencing this or are in this field and don't know much about it, to definitely educate yourself.
Right.
And to make sure you read the fine print.
Yeah, there's a lot that they don't tell you about. And, I chose an IUD and I'm on my third IUD now. I'm a big believer in it. Love it. But the lady who had put my last two in, actually, she's an older midwife and very efficient. Very efficient. But it's funny because, she's whipping around and getting things done and she's just a Johnny on it. But then she's stopped. And even though this was my third IUD, she's like, do you know the side effects of this? Do you know? And she just started listing things off. And it was things that I didn't know, but I think I knew it because, well, this is my third one. And honestly, I'm a nurse and I've looked up stuff and have educated myself on it. So I really appreciated that because
I wish everybody was like that.
She didn't take for granted what I knew or what I didn't know. And I think that that's something that we need to remind ourselves of. Even though we're talking to another nurse as a patient, like, I don't do GYN.
Yeah, our specialties are different.
Yeah, I can learn GYN.
Yes.
But I don't do it, and I never have. I mean, I did a stint in school.
Yeah, of course, we all go through our rotation.
But after that, I mean, that was enough for me to go,
The same for me.
There's a lot of things I could do.
I'm no longer in urology.
Right. I mean.
For certain reasons, yeah.
But I mean, I want to be talked to. Like, I don't have the knowledge, not because I'm not intelligent.
Capable enough.
It's just because I want to be treated the same as
everybody else.
I want you to give me that same information because there may be something big that I don't know that you think that I do.
Absolutely. I agree with that.
And so I even try to give that back even when I know that I'm talking to another nurse. And I'll tell them, if you know this, you can stop me. I won't be offended, but I'm going to talk to you like you don't know because you may not do this for a living. And I've never had any nurse ever stop me and say, I already know all this.
Yeah.
So I think
it's a good point.
A lot.
That's a good point.
Which leads into how we're going to wrap this up with our nursing considerations for endometriosis. So for our nursing considerations, we're going to start with incision care and pain management. So with any incision after surgery, you really just want to make sure that you're preventing infection, keeping the area clean, and making sure the patient knows what it looks like if it's infected. And you want to maintain a safe environment, make sure that everything is clean. And I can't stand any kind of nursing area that's not kept.
Absolutely.
I just feel like things get missed and that's how things happen.
Mm-hmm.
And then you want to make sure that you administer medications as soon as you can to help with pain management right after surgery. And then you want to monitor lab values. Of course, this will all be ordered, but you need baseline, and then you can assess for changes after that. And then you just want to make sure that you identify any early signs of alteration in fluid and electrolyte imbalances. And due to the shutdown of paralysis related to general anesthesia and them not being able to eat or drink, of course, you want to just make sure that you monitor for any alteration in GI function. Of course, anytime you have general anesthesia, I mean, I think this is pretty much across the board, everywhere.
Every surgery.
Is, they got to pee before they leave. Make sure you have bowel sounds, things. You got to make sure that everything woke back up.
Well, I can tell you that they have changed the rule about having to have a bowel movement before you leave the hospital. But yes, you do have to pee before you go.
Yeah, I think some people might be there for days if they have to have a bowel movement. It's one of those, let me know if you don't have a bowel movement within a couple of days. But I think they're supposed to check for bowel sounds.
Yes, they do.
To make sure that, and bowel sounds in all quadrants, of course.
So, of course, we're big on education. We want to educate and inform. And as nurses, that should be like our number one goal, right? You want to educate your patient on diet advancements from their NPO status to clear, and you want to promote self-advocacy, because only the patient can understand, what they're feeling, what they're going through. And if something's not right during the recovery phase, that you want them to be able to reach out and communicate with their provider or their surgical team or their, healthcare team to let them know, hey, something's not right. And you have to remember, in some of the most severe cases of endometriosis, it can affect your bowels. And if it affects your bowels, you may be leaving with a stoma or ostomy. So now not only is your patient probably not being able to have children, they have a stoma now that they may have for the rest of their life,
right,
on top of all the other mental stress and possible depression. Change is hard for anybody, and this is a big change. This is a huge change. So you just want to make sure that you're educating your patient as to why they have to have a stoma. Most of the time it's because of a bowel resection. And the patient's going to need to be educated on that. They're going to need to know how to clean that, how to take care of it, supplies needed.
Right.
And most of the time, you're going to have assistance from a wound care nurse. So that post-op nurse and that wound care nurse, they should be like best friends for that patient.
Oh, absolutely.
So you're going to have that. You guys have to work together in order to give your patient that emotional support that they're going to need before they leave the hospital.
You have to make sure that you advocate for your patients to make sure that they leave understanding everything or knowing a credible site to get information from.
I don't know how many times I ask my patient, do you have any questions? Did you understand what I was saying? Do you need me to show you or explain it to you in a different way? That's not a dig on my education. Everybody learns differently.
Yes.
So as nurses, we need to take that into consideration. Some people are visual, some people are hands-on, some people are auditory learners. So when I'm educating my patients, I try to give them all of that, because that patient might not be a really good listener, but maybe they love to read. So you just have to make sure that you're attending to your patient's needs.
Absolutely. As always, we will link our references to our website, thenursingpostpodcast.com. Be sure to subscribe to our podcast on your favorite platform and let us know what you think. Thanks again for listening to The Nursing Post.